Hi everyone, this is Bill Riley with Medical Advantage Group. We see a number of you signing into our webinar here today. Thanks for joining us. We're going to get started in just a couple of minutes here, so please sit tight and we'll be back shortly. All right, everyone, I've got high noon, so why don't we go ahead and get going. See a number of people on the line here on behalf of Medical Advantage Group and also SIPA. Thank you for joining us for our latest webinar, the Interrelatedness of Behavioral Health and Physical Health. This is the first in a series, the first of 4 webinars we'll be doing on behavioral health and its role with as part of care management. A couple of housekeeping things before we get started here. First of all of the phone lines are currently muted during the presentation. We are going to pause at the end to do questions and Q&A. So please just use the little Q&A panel in your GoToWebinar tool to submit any questions. You can submit them throughout the presentation. We'll pause at the end and our speakers will address them. As always, with these webinars, all of you will receive a copy of the presentation as well as a recording of today's session. I'd like to quickly review the objectives we have today. So number 1 is to recognize the extent of the relationship between mental illness and physical health. Number 2, understand how mental health affects clinical outcomes as well as the total cost of care. And then finally, a solution for addressing mental health in primary care. I'm very excited to introduce our 2 guest speakers today. We've got just wonderful, experienced people who are going to help us out. First is Richard Maye, MBA. Richard brings over 30 years of executive management and administration experience in the health and human service field. Past positions include CFO, COO, Chief Executive Officer. In fact, in his role as Chief Executive Officer of a multi-program rehabilitation center, Mr. Maye was able to double the number of patient visits in some programs within just 2 years. We're also joined by Dr. Mason, who's a practicing psychologist in private practice, over 30 years of experience, specializing in adolescents, firemen, EMTs, as well as consulting work. So with that, Mr. Maye, I will turn it over to you.
Thank you so much, Bill. Good afternoon, everyone. We're starting out with this initial slide that some of us can relate to very effectively. When I work with primary care physicians, which I've done a lot in the last many years, when I ask them what percentage of patients in their primary care practice has a presenting mental health issue, it's almost unanimous that the minimum percentage is 40 to 50%. Here on this slide, I like to begin with some statistical information that illustrates the correlation between mental health and physical health. As we can see, these percentages might be low for some of you out there in the field, and for some it might be a moment that you say, yes, I can relate to that. We do see a high prevalence of patients in our practice that have presenting mental health issues. So when you realize that there is a relationship, as we look at the next slide, we'll get a little bit clearer picture as we go. Next, please. We can see that relationship between physical and mental health has a cost implication to it. Unquestionably, the studies may vary, but the studies are unanimous in indicating that individuals that have mental health issues along with other comorbidities have a much higher cost associated with their overall total cost of care. This slide indicates that cost is 33% higher, and I've seen some, as we'll see on a succeeding slide, that is even greater than that. But what's really interesting for us to make note of is the age of onset of mental illness. As we can see, half of all mental illness begins at a very early age, and 3/4 of mental illness in individuals begins even earlier than midlife. Now, the effect of that is going to be driving up the total cost of care. And one of the things in our learning objectives, as Bill said, is that the project that I work on with MAG has two primary goals. One is to improve clinical quality outcomes by helping patients become more compliant with their primary care plan. And as they do, we should see the total cost of care decline. And here you can see that the high cost of mental health patients were under the age of 60. 79% of that cost is occurring at a relatively young age in our population. Next slide. Here's a bar graph that illustrates a little bit further as to what that relationship is between cost for certain diseases, asthma or COPD, congestive heart failure, coronary heart disease, diabetes, and hypertension. There's no question that regardless, as I said, of the study that one may look at, you can see that is a profound relationship in cost for individuals that have behavioral health comorbidities is significantly higher. And hardly a week goes by, and sometimes even a day, where I'm not receiving more and more information regarding examples across the country of how important it is to integrate behavioral health into primary care, not only from a cost standpoint, but as I said, we want to improve the clinical quality outcomes by getting people compliant with their overall plan of care. I just read this morning where I think the governor in the state of Washington is signing legislation to mandate the integration of behavioral health with physical health in the state Medicaid population. So that's pretty significant, and it's happening across the country as more and more health systems are moving at some degree towards the integration of behavioral health with primary care. Next slide, please. What the project does that I work on with physician practices, and I've spent a lot of years working with hospital and physicians on staff, supervising physician practices, and that relationship has given me the opportunity to design a clinical integration model that we're trying to implement, as I said, in some of the practices that MAG works with. And this slide here gives us just a brief thumbnail sketch on how that, what that model consists of. And what we start out doing is we stratify your patient population into disease registries, usually focusing on the 3 highest disease by volume, and that could generally be diabetes, hypertension, COPD, CHF, and even behavioral health. So we want to stratify our patients by volume, and then it's just not a numbers analysis for volume, but we want to segment those patients into risk categories. We use a algorithm to assign patients in those disease registries into risk categories. Now, why do we do that? Well, when we integrate behavioral health into primary care, we have limited resources available to us. Even if the behavioral health specialist would be on site full-time, as opposed to maybe 1 or 2 days a week, their time is limited. And we want to focus our time and resources on where we're really going to generate the best improvement on clinical quality outcomes and lowering that total cost of care. So we're going to use a set of algorithms, as I said, to stratify and risk segment our patient population. And we're going to set up a workflow referral process once those 2 steps are done to steer the patient towards the proper care pathway. One pathway could be towards the behavioral health specialist, and another pathway could be to the care coordinator, both of which are very important functions in the integration of behavioral health and primary care. And yes, some patients will go down both pathways. They'll go to the behavioral health specialist and the care coordinator as well. What we want to try to do when we make that referral to the behavioral health specialist is focus in on why the patient may not be compliant with their primary care plan, why they may be deteriorating in their quality metrics. Some of them are chronically depressed, anxiety-ridden, or have other issues that Dr. Mason will speak to in a moment. But what we want to try to do is, in coordination between the primary care provider and the behavioral health specialist, is not work in silos where the primary care provider is only focusing on a non-compliant, high-risk diabetic patient with an A1C well over 9. That's going to be part of the referral that the provider will make to the behavioral health specialist. But when the specialist receives that referral, they want to try to blend their therapeutic modalities into why that patient isn't aware of the seriousness of their disease, or if they are, why they aren't showing more interest in managing that disease. So we want to get them to understand their disease, the serious nature of their disease, what can happen if they would continue to not manage their disease effectively. But we want them, the end goal after the behavioral health specialist intervention or the care coordinator is to actively participate in their plan of care with their physician and their provider. And that means keeping their office visits, their lab appointments, their foot exams, their eye exams, whatever the case may be. And as I said, if once we get these patients, high-risk patients, under control to some degree, emotionally, and physically, we can then have a serious impact on reducing the total cost of care. We're going to see fewer ER visits and fewer hospitalizations. The need to refer out to specialists should decline for many patients, as well as surgeries should also decline, where, for example, a diabetic patient, instead of losing their toes, or even worse, can get that diabetic situation under control and managed because of the care coordination and behavioral health intervention working in sync with the primary care provider. Next slide, please. Here's an example from a primary care practice that I worked with. That in the upper right-hand corner, I know you can't see it, there's a box that's black, and in that box it says that the goal is to have those patients with an A1C between 7.1 and 8.9 below 20%. So on the left-hand side, you can see that when the program started with the integration of behavioral health and care coordination in 2013, how that practice has been able to progressively move towards that goal. And this is part of the process that we would work on with your practice, is after we get the stratification and segmentation process completed, and we have our referral system nailed down for the right care pathway, we're going to look at how we're going to measure the success of our interventions, so that each quarter for those 3 highest by volume diseases, we're going to set up some data metrics, such as this one, that we can crank out some really meaningful reports that are used internally, certainly, to see if our interventions are really working or need corrected, but also in time, we would want to use this kind of data externally so that your payers can get a sense of appreciation that from the integration of behavioral health into your practice, you're making some really significant improvements in controlling their total cost of care for their patients enrolled in your practice. So we want to make sure, again, that we're not operating in silos, and the care coordinator, the behavioral health specialist, and the primary care physician providers will meet regularly. And now that could, depending on the size of the practice, be once a week, once or twice a month. Well, they'll have, for lack of a better way of putting it, a treatment team meeting where they're going to discuss their high-risk patient populations. They're going to look at this data, and they're going to discuss interventions that are really working and could be applied across a broader spectrum of patients, as well as interventions that for some really high-risk, non-compliant patients that just aren't working so well. And what do we need to do as a team to tweak that intervention? Perhaps the care coordinator needs to bring more community resources to bear. Perhaps the behavioral health specialist may need to make some changes in their approach to the diseases that are seeing certain patients for. So it is a collaborative care model, because just the co-location of a behavioral health specialist does not in and of itself mean you have behavioral health integration. Integration comes clinically, where the behavioral health specialist and the provider, and hopefully if you have a care coordinator, work in tandem with community resources, the patient's family, patient caregivers, to make sure they're getting diabetic education, obesity counseling, respiratory therapy counseling, whatever the situation may be, that those gaps in care are closed very effectively. Next slide, please. I'm going to turn the presentation over to Dr. John Mason now. I just will say that Dr. Mason and I have worked on this sort of program for many years, and with his experience and his interest in integrating behavioral health into primary care, it's really been successful at the practices where he himself appears on site and provides the therapeutic intervention. So, Dr. Mason, I'll turn it over to you.
Hey, thank you, Rich. Hello, folks. My name's John Mason. Everybody calls me Doc because I used to be a paramedic. And I have worked with Richard for quite a few years on a bunch of different projects. This one's been probably one of the most exciting. Next slide, please. In order to understand, what's going on, there's been research for years that talks about the interaction between physical and mental health, and they both have a bearing on each other. Take, for example, physical health. We have a condition called a chronic pain syndrome, which is a direct result of a patient that's in chronic pain. And that pain takes a lot of psychic energy to deal with, which in turn has an impact, sometimes a very severe impact, on the mental health of the patient. By the same token, we know that mental health problems can cause physical problems, such as high blood pressure, heart conditions, ulcers, autoimmune diseases, and those types of issues. A lot of the research that went into the impact of mental health on physical health was done by Dr. Hans Selye. Next slide, please. Selye was an internist. He's out of Canada. And he noticed that a lot of his patients who had physical diseases also had decline in their emotional issues also. And what he suggests is that if you look at this model, you have high stress and low stress, minor stress, and major stress. And he says there are two components. The first component is the stress itself, and then the second part is where that falls on this paradigm, this design here. He suggests that any stress, if it goes on for any length of time, can be detrimental. And he calls that the general adaptation syndrome. So you could have high stress that might be minor in nature, and it can cause as many problems as a major stress that's low in nature, okay? The main component is how long the stress goes unrelenting and how far out of the dead center it may be. From this stress model, we can take a look at the development of mental health issues. And let's go to the next slide. Okay, any intensification of unresolved stress causes breakdowns in both the physical health and mental health of the individual. There is an interaction between stress and physical disease, as we noted before. And disease such as cancer or diabetes, high blood pressure, any of those kind of long-term diseases can cause stress, which may reduce the ability to deal with it emotionally, and the process can be sped up because of that. And the same is true for mental health problems. If you have unresolved stress, you can make the problems can be made worse. And the one thing you have to keep in mind that we don't think about a whole lot is, just like with physical stress or physical energy, mental energy is limited, and we need the sleep to rejuvenate those abilities to deal both with physical and mental health issues. And what happens in both of these situations is that the brain, for example, with dealing with emotional issues, it works in the background and parcels out energy for each component of life during the day. And if someone's having, for example, more problems at work than what the brain is proportioned the energy for, it will draw energy from other areas of the individual's life. So it may take energy from interpersonal relations, it may take energy from concentration, and if that energy draw is really severe, then you start to see breakdowns in the ability to cope, and usually that turns into depression. Okay, next slide, please. Now, major syndromes are common diagnoses. So if you open up the DSM-5, you're going to see things such as depression and anxiety, PTSD, syndromes of childhood, such as ADHD and panic disorders, and some organic-based syndromes from stroke and brain damage. Now, our model is, again, based on unrelenting stress. So we have stress even when we're behaving normally, okay, but we're able to manage it. But as the stress continues unresolved and it gets worse, then we move into a neuroses, or the neurotic stage. Neuroses simply means that the mental condition, let's use the example of depression, becomes the predominant part of the individual's personality presentation. Same way, for example, if somebody has an unresolved grief syndrome, the same thing would be true. They're preoccupied with their grief, which inhibits their ability to operate on an appropriate basis. If the stress still is not taken care of, then we move into psychotic behaviors. And these behaviors are the ones where you get the bizarre behaviors such as hearing voices, visual hallucinations, those types of things. And at that point, what's happening is the mind is trying to come up with, basically an alternative reality, because it can't handle the stress that it's confronted with day by day. Now, what's interesting about this model, the first thing is that the transitions are not abrupt, and that's why we have the slash marks on this diagram. It's a transitional thing, okay? So you may see some things, for example, as we move into a pre-psychotic state, the individual may report hearing things. And when you question them, they can't really tell you what they're hearing. The normal comment is, well, it's like I'm in a stadium and I just hear a lot of background noise. And as they move further into the psychotic state, they begin to hear audible, identifiable voices, and then to the point where they can tell you who the voice is and what they're saying. And what's interesting about the auditory is that most of the messages that they hear are self-destructive or self-defeating in nature. Not really sure why that is. But the point is that it is an exaggeration of normal behavior. Think about the way you process a problem. Some of us, we all talk to ourselves. Some of us do it non-verbally. Some of us do it verbally. But talking to ourselves is a very normal behavior. Okay, again, as you move into the neurotic state, it becomes more predominant and it interferes. And then as it moves into psychosis, it's much more bizarre. However, the behavior itself rests in the normal behavior. And so as a psychologist, we're looking for a lot of different things. We may look at the results of testing. We look at, for example, clinical presentation. We look at stress factors that the individual may be going through. And that's important to remember because in the model that we work with, we feel that it's paramount to have the behavioral health specialist actually on site. And the reason for that is that we can immediately deal with the crisis rather than the doctor having to refer that individual out to a therapist. They may have to wait a week or two, and if the patient is really severe, the doc's going to send them to the emergency room, which runs the cost up. If you're on site, the doctor can walk down the hall, can knock on the door, and say, I have this individual that I need you to see immediately. And then through the triage process that we use, we can determine whether that patient needs to be hospitalized or not. In 90% of the cases, if we can stabilize them in that first visit, they don't need to be hospitalized and they don't need to go to the emergency room. And that reduces overall costs. It also, being on site, also gives us the opportunity to go back to the physician and say, look, this person's doing this, they're saying this. You may want to consider, medication. I've set them up for another appointment, and, this is what we're going to do. This is our treatment plan. So we say we cut a lot of red tape and we cut a lot of time consumption by being right on the spot. And there are two examples that I would share with you that show how important that is. The first example was a woman who was married for about 21 years. Her husband was an alcoholic. And the night before she came to the clinic, the husband went out in the front yard and committed suicide by shooting himself in the head. Needless to say, when she came into the clinic, she was an absolute mess. They came to me, I saw her, I was able to stabilize her, I was able to make sure that she had a safety net and had people that could stay with her. And I spent time with her initially and then saw her in therapy on a regular basis for about 5 weeks as we got her through the grief process. The second case was a woman who was middle-aged, and she was diagnosed with MS. And the diagnosis was out of the blue. She didn't expect it. I'm not even sure the internist expected it. But the internist came to me right away and said, I'm really concerned about this woman. You need to see her. And I was able, again, to prevent her from going into the hospital for psychological reasons by doing, crisis intervention and stabilization during that first visit. And then I began to see her on a regular basis. I saw her weekly for a while. Now I see her biweekly. The condition, she's much more capable of dealing with the condition because we've been able to build up her emotional energy quite a bit. and I think we've slowed the process down quite a bit. So those are two examples of why it's important to have somebody on site to do treatment. The other issue there too is the patient is familiar with the surroundings. They go to these doctor's offices on a regular basis, so they don't have to learn a new place. They don't have to travel to a new place. They know all the staff, and it makes them much more comfortable and much more incentivized to take part in the therapy. Now, when we talk about the major syndromes, we talk about this normal through psychotic track. Next slide, please. The second track is what we call personality disorders. Now, with personality disorders, we're looking at a trauma-related event. Probably one of the most common ones is sexual abuse or maybe physical abuse, death of a significant other, a physical injury or illness.
Dr. Mason, we're losing your audio a bit.
Oh, okay. What do you want me to do? What do I need to do? Hello?
Doc, I can hear you.
I know. Bill? Bill?
Yeah, very good. I'm sorry. I think we're back. Thanks a lot.
Okay. Physical injury or illness where there's some debilitating component to it, disruption in relationships such as a divorce of parents or something like that, substance abuse, and obviously the death of a significant other. Now, I'm not Freudian by any means. He doesn't translate real well to the modern world, but some of what he says makes sense. And according to him, he says trauma causes disruption in the development of the personality structure in a specific developmental stage. And because of that, normal development of a personality cannot occur. So if you have, for example, a trauma as an adolescent, like, for example, a death of a parent, there's a part of that personality development in adolescence that stays frozen and it doesn't move forward. And with that example, Freud theorizes that's one of the reasons why you have sometimes rebellious adults. And you can look into the DSM, and there's a whole diagnostic system that deals with personality disorders. The issue with personality disorders is it's different than dealing with a stress situation. Okay, you don't have, you deal with the stress in a rational manner and work through and come up with methods to resolve the issues. With personality disorders, the therapy is a lot more long-term because you actually are working at trying to repair the personality via therapy and medications. Some examples of those diagnoses, probably one of the most common known one, are borderline personality disorders. Obsessive compulsive disorders tend to be up there, like maybe second in line. You have an antisocial disorder, anxiety disorders, there are quite a few. But you need to keep in mind that the therapy with these folks is a lot longer than what it's going to take with the stress-related syndromes. Next slide, please. With treatment methods, everybody has their own favorite way of approaching therapy, and you can, being in practice for 33 years, we've seen a lot of stuff come and go. Also, the same way with the training. When I was originally trained, I was trained in Carl Rogers' client-centered therapy. I don't know how many of you are familiar with that at all, but, or not, but it was a move beyond Freudian psychotherapy, and it involved a lot of reflective listening and not a lot of advice. Today, we are more attuned to the cognitive behavioral type therapies, because we can gain data to look at the effectiveness or non-effectiveness of the therapeutic approach. To me, you can get hung up on one therapy approach, and that creates problems because not everybody is going to be able to respond to the therapeutic approach that you present to them. For example, one of the cognitive approaches is rational emotive therapy. And that approach deals with challenging irrational thoughts. It's very difficult to challenge irrational thoughts when you're dealing with someone who may be like a borderline in their intellectual ability, or even mentally retarded. When you use rational emotive therapy with children, you have to teach them the difference between rational and irrational thoughts before you can even work with them. So there are other therapies that you can use, for example, on kids. One of the approaches is reality therapy by Bill Glasser. And you were involved in teaching ways to make rational decisions, accepting consequences of the decisions, and giving the person homework. And most of these cognitive therapies involve giving people homework. If you have a real serious case, in other words, you have somebody that is depressed to the point that they're agoraphobic, therapy plus medication would be called for. And used in tandem, the therapy plus medication is more effective than if each were used separately. And combining psychological treatment with medical treatment enhances the total treatment effort, because we can communicate back and forth, myself and the provider. And if I got somebody, for example, that's being non-compliant with their diabetes medication, then I can approach that from a therapeutic standpoint and try and get over the inertia of taking the medications. Generally speaking, when you're dealing with the major syndromes, we're looking at probably 8 to 10 sessions. That seems to be the average before you get to the point where the individual stabilized. So based on that concept, when we're working with the private practitioners, we'll go 10 sessions and then report to the physician where we are in the therapy, if it has ended, if it hasn't ended, and what the treatment plan is for the next sessions. But normally we can get things resolved, unless, like I said, we've got a long-term illness or something like that. 10 sessions seem to work pretty well as a cutoff point. Next slide, please. So as we said before, having both services in the same office allows for instant communication. And we find this to work particularly effective in emergency situations. The patient's more comfortable due to not having to go to another office. They know the staff, they know the building, and that really makes them more willing to come to therapy. I know when we started this out early on, the question came up was, well, are the patients going to be comfortable meeting with the therapist in a normal treatment room? Well, the answer to that is yes. As a matter of fact, it goes again with the familiarity. They're used to coming into a treatment room. Now, obviously, we're not Freudian, so we don't have them lay on the couch or anything like that. But we have, the treatment rooms are very comfortable. We try and make the patient very comfortable themselves with comfortable chairs and that type of thing, and it works pretty well. Again, 10 session increments, and we assess the progress at the end of 10 sessions, and further treatment or termination is executed. Next slide.
Okay, thanks, guys.
That's my part.
Great. Yeah, excellent. Thanks so much, Dr. Mason. Before we go to the summary, I just wanted to maybe share a couple of questions that have come in over the course of the broadcast. One is around just the employment model. Is there a certain type of employment model to use when bringing a behavioral health person on board?
Yes, there can be. There's several different options. Some practices choose to employ the behavioral health specialist as part of their practice, and either part-time or full-time, and capture the billing by that employment model. Another method is to rent space in your practice to a behavioral health specialist and gain the revenue from that rental income, and perhaps even work on a split billing arrangement. And another model would be to employ a behavioral health specialist as an independent contractor rather than employee, and do a fee split on the billing. Well, that's just three rough examples that I've seen work through primary care practices, and there can be hybrids carved out of some of those even, but essentially, depending on the size of the practice, one of those models is very workable. And as Dr. Mason said, some practices worry about, is space going to be available? What kind of space do I need? And generally speaking, you just use an exam room that isn't being used by a physician or provider to start with, and see how the demand flow works from that standpoint there. Exam rooms work very effectively because the patient is used to that environment. So it's a very workable situation, even in the smaller practices. Right. Thanks, Bill.
Thank you, Richard. And there's a related question here around just, is there a financial benefit for the practice, or how does the practice benefit financially?
Absolutely, that's a good question, because a lot of practices will want to know what's there going to be the return on the investment. Well, we know that from experience that one of the returns is improved clinical quality outcomes, as we mentioned previously, and another one is reducing the total cost of care. But there are several ways a practice can realize a monetary return on that investment with a behavioral health specialist. As I mentioned a minute ago, you can choose to bill for the behavioral health specialist time, and that can produce a revenue stream. You can also, if you're a CPC Plus, especially Track 2 practice, your payments from CMS for being CPC Plus recognized can go towards offsetting the cost of the care coordinator and the behavioral health therapist, but also because the patients are becoming more compliant with their primary care plan, you're going to see an increase in visits to your practice, increase in lab work. You're going to retain those patients instead of referring them out to specialists and perhaps not seeing them again, or at least not for a while. Your retention rate will improve, and patient satisfaction will grow because they're getting intensive attention from care coordination and behavioral health intervention, and as they see their quality of life improve, they'll mention that to others and become, in some sense, a word-of-mouth marketing tool for your practice.
Right.
There are several other ways to monetize the behavioral health integration that I've identified, but for the sake of time, that's just a handful of them that I'll mention now.
Right. The one thing I would point out too is that regardless of the relationship that the therapist has with the practice, the only people that the therapist sees are patients from that practice. In other words, like when I do the work up at Bell Fountain, I don't have my shingle hung out for the general public, okay? And we actually have turned people away because they weren't patients within that practice. And that makes a big difference, I think, again, in terms of capturing the patients and keeping them in the general practice, because they know that, for example, in Bell Fountain, just use that as an example again, there are no psychologists in Bell Fountain at all, other than at the Public Mental Health Center. And so consequently, there is a premium for people like me in that community, but because of the arrangement that I have, I only serve the patients at the clinic.
Okay, very good. So with that, guys, if you want to hit the summary, we can start to wrap up.
Well, essentially, hopefully, we've been able to draw a pretty solid line between point A and point B on the relationship between behavioral health and physical health. We know from the studies that have been done that comorbidities with behavioral health and physical health increases the total cost of care. It can certainly negatively impact the clinical quality outcomes due to the patient not understanding their disease or maybe not being compliant with their primary care plan. Unfortunately, but it's getting better, the correlation between physical and behavioral health is often not recognized. But when it is, when we implement a clinical integrated model of care like we've talked about briefly here during this presentation, you do see a significant improvement in clinical quality outcomes, particularly for those high-risk, high-cost patients, and a reduction in the total cost of care. So it's a model, as I said earlier, that is, albeit somewhat slowly, moving across the country, but it is moving and it is gaining momentum.
Right. I think that this is an exciting project because people, professional and otherwise, are beginning to recognize, like Richard said, the connection between behavioral and physical health. And I think that just given my experience in the one clinic that I'm working in, I can see a difference in an improvement in the majority of the patients that we treat, just because we're giving them tools behaviorally to deal with their stress and to deal with their issues. And I can see it in the doctors too. I have doctors come to me practically every week, saying, man, I don't know what you're doing, but keep it up because this patient's a lot more compliant. They're showing improvement. This is really good. So we know that it works. We've looked at the metrics at that clinic, and we see improvement. So I think this is something that's very exciting that, hopefully the medical people that are listening there today will consider this some more as a possible objective and a new way to approach things.
And that's a good point you made, Dr. Mason. Just to wrap up on my comments, where Dr. Mason and I started this project, the physicians were somewhat skeptical, and over 6 months, 9 months period of time, depending upon the different physician and providers. They are now fully endorsing the concept and will talk to their colleagues anytime they're called upon as to the degree of success that they've seen with the integration of behavioral health into their primary care practices. So to echo Dr. Mason, we hope that those of you that are on the line and join this webinar will consider doing something like this if you haven't already in your practice. And as Bill will mention, next week's webinar, we go even deeper into this subject. So thanks for your time, everyone.
Thank you.
Okay, Richard Maye, Dr. John Mason, thank you so much for the presentation today. Great job. We've listed some references here. As Richard just mentioned, this is the first in a series of behavioral health-related webinars that we're doing to SIPA members from Medical Advantage Group. The next one coming up next week, we'll start to drill into more topics more narrowly, starting with depression, anxiety, etc. as we go forward. I can see that a number of you on this session today have already registered for some of these additional sessions, so thank you for that. As always, we'll be following up shortly with the recording for today's session. Thank you for your attendance, and enjoy the rest of your day. Thank you very much.